You don't need the luxury brand, and their acne is impacting their life, their job, their school, their social life, their marriages, their relationships. If it's just one size fits all, it's not a balloon that we're filling. No tan is healthy. Sitting in the sun, burning, and it scares me when I see a sunburn. He can or she can put the patient on a 2-week wait scheme compared to a year wait for things like psoriasis. The patient gets seen by a dermatologist within 2 weeks.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being. Dr. Hiba Injibar, you've been a dermatologist for the last 25 years. You practiced medicine in Saudi Arabia and Lebanon in the past, then you moved to the UK. Culturally, people look after their skin more in Lebanon and Saudi Arabia than here in the UK. Why was the move necessary?
Quite frankly, we just wanted to move away from the Middle East, which, we love our country, we love Lebanon, we loved living in Saudi Arabia and working as expats. But we just wanted a new life for the kids, and that's why we moved. So the move was not based on career choices or a job offer. It was a family decision.
Yeah, I totally relate to that. I moved to the UK 15, 16 years ago to marry my child, his father, now ex, but yeah, I totally get that. Was there a defining moment in your life when you decided, I want to make people look pretty? Then you went ahead and joined medical school.
And medical school is a 4-year graduate degree program. So I did that whole 4 years. And by the end of those 4 years, you have to choose your specialty, right? It was time to choose my specialty. And I thought, I love a lot of things, but I love children. Let me go into pediatrics. So yes. I did my internship in pediatrics, and I didn't like it at all.
Why was that?
Well, because what I love about medicine is communicating with the patient, talking to the patient, making the patient better, making the patient happier. And this is what drew me eventually into dermatology. In pediatrics, you can't really communicate with the patient. The patient cannot tell you what's wrong. They're crying all the time. You feel sorry for them. Parents are very anxious, and you have to deal with the parents who are not the patients and sometimes ignore the patient because the parents are very nervous. And then we had to go on the ward. I spent a few months on the cancer ward with children, and that made me so depressed. And this is when I realized dermatology is wow. This is what I want. And it wasn't initially about cosmetic dermatology. Of course, we had some training with aesthetic medicine, but the dermatology core training is skin diseases, and that is what caught me. It's just the fact that I'm a very visual person, tactile person. I like to see things. I have a visual memory. So it was so interesting that compared to other specialties where you sometimes have to rely on blood tests and imaging to actually diagnose the disease, in dermatology you actually see it and it's looking at you. And it's so visual. And I loved the surgical aspect of it because I found it so interesting and so varied. You're not stuck with, let's say in pediatrics, it was colds and, runny noses and vaccinations. Here, every single patient is different, even if it's the same disease, because you actually see the disease. Every single rash is different. Every acne patient is different. Hair loss, and it's the hair, the nails, the skin, and it's the largest organ in our body. So that is what attracted me. And up until now, even though I've been practicing for 25 years now exactly, because I qualified in 2000. I love cosmetic dermatology, and I love aesthetic procedures, and I love lasers, but I'm still cling to medical dermatology. So I still want to treat rashes and, fungal infections and nails and hair. So yeah, that's what drew me. And it's also like the lifestyle. Dermatology is it's extremely competitive to get into a dermatology program, mostly because of the lifestyle. You don't get emergencies. You don't need to do night shifts in the hospital mostly. You can be fully private. So lifestyle is very appealing.
Yeah, of course it is. And I know that the exact complexity that fascinated you and you found amazing is why dermatology is such a challenging field.
Yes.
What you found amazing is what makes a good dermatologist a very rare thing. Let's start with one of the most talked about challenges in skin condition, those stubborn wrinkles. Why do some people get wrinkles earlier than others?
So genetics does play a factor, of course. Ethnicity and genetics do play a role, a small part, let's say. Lifestyle is the major cause of early wrinkles. And of course, when we're talking about lifestyle, 90% of wrinkles comes from sun exposure. So early exposure as a young child to an adolescent, to a young adult, to a lot of sun with no protection will make you age earlier. So there are studies, and you can even find them online. These images are common, and I think I talk about them. I show the image in some of my talks and videos of identical twins who were they're identical twins and they were raised differently, or they grew up differently, or their lifestyle is different. One is exposed to the sun and one is more protected. And you can see a dramatic difference when they start aging in wrinkling, leathery skin, sunspots, fine lines, and this is all part of aging. Then other lifestyle things, smoking, definitely can age you more because of its oxidative stress. And also, like some people, some women mostly, they do take care of their skin early on by using sunscreen, good active ingredients. They consult dermatologists early on. They might start doing procedures as preventative measures early on, so they kind of delay their aging, and you can do that, absolutely.
Hearing you talk about sun exposure in childhood and going on holidays and all the rest of that, I think that's one of the reasons that I still have half decent skin at 46. I never go on holidays. No, I say never. I went to 2 holidays in my entire life. And this might really, I'm an indoors person, I'm a domestic person wholeheartedly, so it might be one of the reasons. People spend hundreds, if not thousands of pounds on skin creams. And are we just paying for fancy packaging?
You might be, yes. There are some luxury brands. A lot of them, actually, the way they sell makeup, they do package some creams and sell them for hundreds of pounds, but they might not be effective. They might be very expensive moisturizers, because if you think about it, when you need to buy a cream and use it, and if it needs to have active ingredients, even if it's not prescription, of course, as dermatologists, we prescribe some creams which are anti-aging, but even the ones that are not prescription, it makes sense that such creams, if they are going to have at least a decent concentration of active ingredients, you buy it from a pharmacy. You don't need the luxury brand. I think that just adds to the price, but not necessarily to the effectiveness of the cream.
Yeah. You talk about active ingredients. Most of us, me included, I don't know what active ingredients to look for. Off the top of my head, I want to make my skin moisturized and hopefully delay the appearance of, like, what we say, anti-aging. So which ingredients I should be seeking to moisturize my face to begin with?
There are active ingredients that work on boosting your collagen, hydrating your skin from within, antioxidant stress, as in normalizing your cells, preventing pigmentation or erasing pigmentation, improving fine lines, preventing fine lines. So as a dermatologist, that's what I want my patients to be using. So the main ingredients would be vitamin C.
Vitamin C.
In concentrations of 10% or more. You wouldn't find 10% in any creams. It's more medical grade cosmetics that's in pharmacies or dermatologist offices. Glycolic acid is a very nice one.
Glycolic acid.
Yes. Okay. Something I tell all my patients to use, and I've been using this for 30 years. It belongs to the range of creams we call alpha hydroxy acids. They exfoliate the dead layer of the skin, because when you exfoliate, when the cream exfoliates your dead skin cells, you get a glow because you lose that dull texture and look.
All right.
It boosts the collagen and prevents pigmentation. of course, retinol or tretinoin, which are vitamin A.
Vitamin A.
derivatives.
Retinol or?
Tretinoin, which is a prescription grade.
Okay.
And even retinol is prescription grade, except for like very low concentrations, like 0.2, 0.1, which you can buy over the counter.
Will I benefit from the low concentration?
You will. At least it's better than nothing.
Okay.
And retinol will boost your collagen, push your fibroblasts to produce newer collagen. It exfoliates the dead cells as well. It hydrates the skin from within, including glycolic acid. So that is how you would improve your skin texture, keep that youthful, glowing look. And of course, you would need moisturizer. But I tell my patients, if you feel like some people have inherently oily skin, they don't really need to moisturize. If you feel your skin is dry, and of course, when you use these acids, your skin will dry a bit, you will need some moisturization. But moisturizers are not the mainstay of good active ingredients.
Okay.
You can use a moisturizer in the morning with sunscreen. There are some medical grade ones that I like and I recommend to my patients. We can mention later. And of course, the best thing is sunscreen daily.
Yeah, amazing.
And I think you will mention this
now,
later.
You mentioned 3 ingredients. Can I use them all at the same time, or do I have to use them one at a time, like one in the morning, one in the evening? How does this strategic setup go?
So I always tell them to use vitamin C in the morning. Because it's antioxidant, so the oxidation you get from the sun exposure, it prevents it from
That's before
damaging.
the sunscreen or after the sunscreen?
Before
the sunscreen. Okay.
And then you can apply your glycolic acid. You can use it in the morning, and then I would tell them put sunscreen and moisturizer. And then all the retinol and the tretinoin and the vitamin A derivatives are night creams.
Okay, it's so good.
So you can use them at night. If you need a moisturizer, you put it over them. And you're all set. It's just 5 minutes, 2 minutes.
Now, anti-wrinkle injections are super popular these days. What do I need to know before I get them?
So anti-wrinkle injections are the mainstay of cosmetic, like they are the gold standard of cosmetic dermatology procedures. And they are divided into basically 2 things. So we have the botulinum toxin, also known as Botox, which are anti-wrinkle injections that target the expression lines. So they are injections that relax the muscles that are pulling on the skin. So when we're frowning, we're expressing, we're smiling, we're tightening our neck, the muscles are pulling on the skin and causing it to wrinkle and to age. So botulinum toxin is one of the anti-wrinkle injections that relaxes the muscles, thereby preventing this movement and relaxing the skin at the same time.
So if I have these lovely lines here or smile lines?
Smile lines would not be anti-Botox injections. Okay. Smile lines would be the next thing I'll talk about. It's more for, this frown, the 11, they call it the 11 or they call it the frown, the forehead lines, the smile lines when you smile, which we call crow's feet.
I have that.
Yeah, crow's feet. And Botox is also done. Advanced Botox can be done to repair the smoker's lines, the neck muscles, the tight neck muscles, which pull on the skin down. Yes. So these are the Botox, the anti-wrinkle injections.
You said smoker's line. So if I'm a smoker, if I was a smoker, would I have lines here?
And you can have them even if you're not a smoker, but we call them smoker's lines. It's, when you purse your lips, some people have lines and they don't like them. So the Botox, the botulinum toxin can relax the muscle you use and thereby relax these lines. Okay. It can be used for the frown lines because also there's a muscle that pulls on the angle of the mouth. Yes. So we can relax that muscle. The other main anti-wrinkle injections, if you want to call them, are dermal fillers. And dermal fillers are syringes that come pre-filled with manufactured hyaluronic acid, mostly hyaluronic acid. There are other ingredients, but the most commonly used and the safest is hyaluronic acid. So we do have hyaluronic acid naturally in our skin that normally in our youth keeps it fresh and young looking. And as we age, we kind of lose collagen, elastin, and we lose that turgor that our skin has when we're young. So these pre-filled syringes of dermal fillers come with different concentrations of hyaluronic acid that can be injected in the skin and that we inject in different areas to repair mostly volume loss. So as we age, we lose volume in our skin, and that's how we get lines under the eyes, in the cheeks, here, in the lips even, in the temples. So things kind of shrink in, and with hyaluronic acid dermal fillers, we can repair this volume loss.
Makes the skin plump again, right?
Yes.
Now the big question, will these treatments make my facial expressions stiff and rigid? Will I be able to raise my eyebrows or smile naturally? We've all seen those celebrities with frozen faces.
Yeah.
Was that like a bad job or old school techniques?
It's a bad job and maybe old school, but it's technique dependent. So your question is, what should I know before doing it? You need to know, most importantly, who's injecting. Know their approach. Make sure they give you a natural look. Make sure they are extremely well experienced in doing this, so they don't mess it up, because Botox might seem easy, and that is why now it's so commonly done by anyone, which is sad. And that is why you see people with eyebrows that are asymmetrical or funny faces, or they look unnatural. It's because it may look simple, that there are a few injections and that's it, anyone can do it, but no, it is not. You have to really know the anatomy, really know what a natural look is, really, like I do it multiple times a day for 25 years, but I still, every time I inject someone, I make them move, I make them smile and frown, I look at their face, so I maintain their natural look. So you can still smile, you can still frown, you can still look surprised, but without the lines.
I grew up in the 80s hearing about Botox, so it's as old as time. Can these injections also prevent new wrinkles from forming?
Absolutely, yes. They can prevent new wrinkles. So the earlier you start doing botulinum toxin, you can actually turn back the clock. You can prevent aging and prevent lines from forming, because if the muscle is not pulling on the skin all the time, and if you kind of relax it early on and keep doing that, you prevent the lines from forming. So I've never had any lines up here, on my forehead and between my eyes, and I'm in my 50s. So you can prevent the lines. I wouldn't tell patients to start very early. I think, early 30s, some people start I started in my late 20s because I was a dermatology resident and we were training on each other. But you can start
training on each other. I love it.
But and also it depends on whether you're someone who uses a lot of facial expressions or not. But there are some people who use a lot of their muscles when they're talking, and they get early forehead lines and frown lines. So yes, absolutely, it can prevent it.
Yeah. How often do I need to do that, whether I start early or late, to prevent new wrinkles from forming? Is it a monthly thing?
No. So the effect lasts 4 to 6 months. So ideally, if you want to maintain your result, like twice a year, maximum 3 times a year, the more you do it, the longer it lasts. With dermal fillers, the newer advanced dermal fillers would last up to 18 months once injected, and then they dissolve completely. But their presence in the skin, the hyaluronic acid, also stimulates the skin to keep itself hydrated, and it pushes the skin to kind of repair itself. So again, when you start early on with these dermal fillers, even though they dissolve completely, you do get a prolonged result and a kind of a preventative approach to the wrinkles or the lines to a certain degree.
Acne. Let's talk about acne. You also give lectures and seminars about acne. I can imagine that you get lots of questions about this condition, considering how many people have it. What do GPs get wrong when they treat acne?
Acne is a passion of mine. I'm very passionate about treating acne and helping people and preventing acne, because I see a lot of people with acne, a lot of children and teenagers, and also many adults. And I know it's severe impact on their mental health, on their self-esteem, on everything, really, even their education. What they do wrong is they dismiss it as just spots, whether it's sometimes parents, many times GPs, they don't really listen to the patient. They just look at them very quickly, prescribe antibiotics and creams, send them off, tell them come back 6 months, 1 year later. They come back and say, I'm suffering. And then they start seeing signs of depression. So instead of treating the root cause and referring them quickly, they might refer them to talking therapy or might prescribe antidepressants. So it's a vicious cycle and a loop. I think what they mostly do wrong is they don't take it very seriously and they don't refer easily. I get patients coming to me privately, having been in the, with private healthcare and not getting anywhere, and their acne is impacting their life, their job, their school, their social life, their marriages, their relationships. They don't get anywhere. They keep asking the GP to refer them to a dermatologist, to the hospital. And then eventually they give up. But sometimes it's too late. Many times it's too late.
Yeah, because the demand is massive.
I know.
I've always had psoriasis, I'm assuming my entire life. But recently I was diagnosed with flexural psoriasis. I say recently, but in the summer. And my GP, which is a brilliant GP, he did refer me once we figured out what was going on. And I was still struggling. But till now, I haven't seen a dermatologist. That's like 9 months. I walk into a bakery on the high street and almost all teenagers have acne.
Yes.
Almost all of them.
Yes.
I mean, hiding under layers and layers of makeup. What is the root cause of teenage acne?
Acne is a very common disease. 85% of teenagers and adolescents have some degree of acne. It's their hormones and the surge in hormones, namely testosterone, that affects the oil glands in our skin. In our skin, we have oil glands called sebaceous glands, and these glands are attached to the hair follicle, and they secrete a substance called sebum, which is the oil, the thing that hydrates our skin. So these glands, these tiny little microscopic glands all over our face, chest, back, and shoulders, this is where they are mostly predominant. They get stimulated by testosterone, which is the hormone. And that makes the oil glands secrete more oil, become hyperactive. And also in the cause of acne, there's clogging of the pore. So there's clogging and there's excess oil secretion. So that oil accumulates, or that sebum accumulates under the skin, causing these little bumps that we call whiteheads. These are the early, baby lesions of acne. And then these get inflamed with bacteria and inflammation, and that's why you get the big red pimples, the pus, the cysts. But it all starts with the hormones causing excess oil secretion.
And this clogging is probably caused by makeup or wrong
It can
skincare?
it can be exacerbated by makeup, but it is caused by this whole disease that happens in the pilosebaceous unit, which is the sebaceous gland and the hair follicle.
So what do we do about testosterone? Does that mean that we have to fix something internally before we deal with acne?
No. This is like normal levels of testosterone. We have to treat the acne, which is the cause. The hormone levels are normal. Most of these teenagers don't have hormonal problems. It's their normal levels of hormones. It's just a disease, and it's a common disease, and it's prevalent in this age group. But that does not mean that their hormones are wrong, unless they have, and this is rare, it's the minority of women might have PCOS, polycystic ovary syndrome, and they might have excess hormone secretion, then we have to fix it. But they have other signs of PCOS, so they have facial hair, they have hair loss, and then they have the acne. But if they're only presenting with acne, and then they have also abnormal periods. But if it's only acne, we don't rush and test for hormones or do blood analysis or anything. No, their hormones are within normal range, but this is a disease that's more prevalent in teenagers, and we have to just treat the disease.
Yeah, I had PCOS when I was a teenager. I didn't have acne or pimples, but I had the excessive hair, facial hair, and my period was all over the place. Now, this begs the question, how do you treat acne at your clinic?
Sometimes they come in with a bag, they show me their skincare. I ask them, what kind of skincare do you use? Show me your makeup, your moisturizer, your face wash, tell me about them. And then I look at their skin. I look I stage the acne. Is it mild, moderate, severe, cystic, or scarring acne? Scarring acne would be top of the ladder. It's something I take very seriously and I treat very aggressively to prevent more scars. So I would look at their skin and I would assess what stage of acne they are at. So if it's mild acne, as in a little oily skin, some blackheads, some whiteheads, I would treat them with topical medications, like topical prescription medications. Prescribe some creams in addition to skincare, and I would advise them exactly how to use it, what to expect, how to cleanse their skin, how to moisturize, and maintenance treatment. If it's moderate acne, whereby there is some inflammatory component, so there are some spots, red spots, pus, purulent spots, spots with a little pus, then I might combine medication. So I'll give them some oral antibiotics with the topical medications. So not just, so combination treatment works best in acne. And then when we reach the stage of severe acne, scarring acne, then I would not just give creams. They don't really work. And that's when they come to me having tried so many topical prescription medications, benzoyl peroxide, azelaic acid, topical antibiotics, oral antibiotics, and nothing's working. Then I resort to strong medications to stop it, and especially if it's scarring, to completely abolish the acne and prevent further scars. And then I might prescribe a medication called isotretinoin or Accutane.
Okay. How does that work?
So isotretinoin is a medication that is derived from vitamin A. It's a medication that is only used to treat acne, mostly used to treat acne. It works on the pilosebaceous unit, that is the area in the skin where the disease starts, like I explained. So it shrinks the oil glands, it normalizes that pore opening to prevent it from getting clogged. It works on inflammation, so it targets all the aspects of acne. It's a very, very effective medication for acne, whether it's mild, moderate, severe, scarring, cystic. It works in 100% of the patients. And it takes a few months and then the acne is gone. It's only prescribed by dermatologists, so primary care physicians cannot prescribe it. Other specialists, I think, cannot prescribe it as well. So it's only us who can prescribe it because we know how to monitor patients and how to avoid side effects. The main problem with this medication is that it's severely teratogenic. Meaning,
what does it mean, please?
It means that women absolutely cannot get pregnant while they are on it and for 1 month after they stop it, because it causes severe fetal side effects like birth defects. So it can affect the limbs of the fetus, especially when the fetus is being formed. So it's very strictly monitored, and we only prescribe it for sexually active women. If they are on birth control, they have to sign consents, they have to do pregnancy tests before, during. For every prescription, we have to I have to stamp the prescription saying I've done a pregnancy test, it's negative, the patient is on such and such birth control, otherwise the pharmacist will not prescribe it. So that is the main issue with it.
Okay. And how long would the side effect last? You mentioned a month.
A month after you stop it, you can get pregnant.
Okay. I can imagine that it's devastating for a teenager to have indentations and visible marks. It can have a real emotional and psychological impact. Now, I'm wondering, does adult acne stem from different reasons than teenage acne?
Adult acne can be a continuation of teenage acne. So teenage acne does not have to stop when you reach the age of 18. And that is why anytime you get acne, whether you're 9, 10, 15, you need to treat it. You cannot assume that, by the time I'm not a teenager, it's gone. Maybe, but it can progress. So I see patients in their 20s, 30s, sometimes 40s with acne that has been on and off since they were teenagers. But if it just starts, if you've never had acne as a teenager, had no spots, and then suddenly you're, let's say, a 32-year-old woman and you start getting acne, then we have to look at other causes. Is it the makeup that you're using or your face creams that are too greasy and clogging your pores? Do you have some hormonal imbalances? Have you been on the contraceptive pill for a few years and suddenly you stopped it? Then you get a surge of, hormonal imbalances and you get acne. Some medications, are you on any medications that can cause acne? So those would be things that might cause acne in adulthood. And many times we can't find a reason. They just get acne and we have to treat it without digging a lot into the cause. If the cause is not obvious, relating to what I have mentioned, it could be a matter of just, a hormonal imbalance, and we have to treat it.
I guess everything we eat, everything we do, apply on our skin does show up on our face. The skin is not a silent organ. I wake up with a pimple and I wonder, is it the last thing I ate last night? Is it my hormones? Is something environmental? It's really, really hard to tell. Tell me how my diet influences my skin.
To be honest, not to the extent that people think. So there are lots of studies that have been done linking diet to acne or diet to other diseases. With acne specifically, the link is not very strong. Yes, it has been found that a high glycemic diet, so a diet with a lot of sugar, lots of chocolate, can worsen the acne, but it's not a cause of the acne, meaning that some people, and that's what I ask my patients, do you notice that if you eat a lot of chocolates, your acne gets worse? Sometimes they say yes, sometimes they say not really. So I would say if you notice it affects your acne or it makes it worse, by all means, and it's actually healthier for your whole body that you take less sugar. But it's not like a direct link. Some studies have found it, some studies have found a weak link. And if you stop sugar completely, yes, your skin might improve, but you might still get acne. You might still suffer from acne, and you might need to treat it. So it's not a matter of like food allergy, like I have an allergy to tomatoes, let's say, and if I stop tomatoes completely, I'm not going to get that itchy rash or urticaria. There, the link is very close and direct. With acne, it's sometimes of a hit and miss. The other link was found. Lots of people come to me and they say, I've cut dairy completely out of my diet and I still get acne. I'm like, yeah, because it's not directly linked. The newer studies have found maybe a link with only skimmed milk and not full fat milk or cheese. So yeah, it's a hit and miss.
Milk is a thing that will give you acne.
Not necessarily. Okay. There was a link. It might make it worse only, or it might flare it up.
Okay. Is there a reason why some people might scar more than others?
So it might relate to like ethnicity and skin color. Yes, we do notice, and I do notice that Asian skin can scar more. Black skin can, produce some types of scars more than white skin, like keloid scars. It has to do also with the depth of the injury. Like how big is this wound or the surgery or the burn? How bad is your acne? Is it cystic acne? It will leave worse scars. And how the wound is stitched. For example, you have a big cut, you rush to the A&E, they just suture it very quickly because it's the A&E, or you have it done by a plastic surgeon or a dermatologist, which is very careful about how your skin will heal. Mm-hmm. Then you get a better scar. So there are multiple factors on why you would scar.
Yeah. Is there like the golden window where early intervention will make the biggest difference in how a scar heals?
Yes. So the earlier it is treated, the better the outcome. So there are recent studies that point to the fact that as soon as stitches are removed, we can go ahead and do some mild intervention to help push the wound in the right direction to heal. Some things like non-ablative fractional laser at a very low dose that helps promote healing and improves wound healing. And then if the scar forms and it is unsightly and the person wants to treat it, yes, the earlier the better. When the scar is still fresh, it's been like a few months, sometimes even like a few years, but not like 10, 20 years. It responds better to treatment before it actually becomes a very formed old scar. But having said that, I treat scars of all ages. So I treat people with acne scars who haven't had a single spot of acne for 20, 30 years, but now they want to treat their acne. Or a trauma scar or a wound, a scar that is very old, it can still respond.
What's a trauma scar? Like a hit in my skin?
Yeah, like you fell on the, on the street, you hit your chin, you cut it, blast injuries, that would be things like a knife injury. So these are trauma scars, basically.
Yeah, I see those over-the-counter creams for scars. Any good?
Not really. No, the only thing that might give a little benefit would be creams containing a good concentration of silicone, but they're barely scratching the surface, so they wouldn't really do much for scars.
Okay. Let's have a look at diet. You do stress the importance of diet for skin health. Which skin conditions that might be affected by poor diet?
So psoriasis is one.
Really?
Yes.
I thought it was an autoimmune disease.
It is, but it's also linked to metabolic syndrome. So high cholesterol in the blood and high triglycerides might impact psoriasis. They're all linked together. Acne, we talked about the fact that it might not be, and hair loss is not like about what you eat, but if you have some deficiencies in some things like iron, vitamin D, if you have a very restrictive diet, let's say whereby you're not eating enough iron, you might get hair loss. If you're on a very strict diet whereby you lose weight suddenly and a lot, you can lose your hair. So hair loss is one of them. But otherwise, it's just, seborrheic dermatitis, seborrheic eczema, a type of eczema. Recently, I was reading an article that they found that might be linked to a poor diet. But
should I supplement my diet with vitamins and minerals?
I say only in this country, because we're not exposed to the sun on regular basis, the only thing you need to supplement your diet with is vitamin D. Anything else, if you have a varied diet, a well-balanced diet, and you're eating meat, fish, vegetables, fruit, dairy, no, you don't really need to. It's only when you have a deficiency. So,
skin care products, all those skin care products that we buy from pharmacies, they are not medical grade, are they?
Skincare products, it's a huge market, a multi-billion dollar and pound market. It's, of course, no human, maybe AI now can keep up with how many brands, but no human brain can keep up with all the different skincare products. The good skincare products, let's say rule of thumb, good skincare products are bought from a pharmacy, not from a department store, and they are either recommended by your dermatologist or by your skincare specialist or maybe the pharmacist. And a lot of them are over the counter, so they're not prescription. So you don't actually need a doctor's prescription and stamp to buy them, except for some, yes, you do. Like I mentioned, the retinol, the tretinoin, which are also unsafe when you're pregnant. So you need prescriptions for those. The others, you can buy them over the counter. You just need to know what to buy, what percentage, which brands are good, which are pure. But the rule of thumb is they are in a pharmacy. They are not sold by someone who also sells you your lipstick or recommends your, T-shirt or blush. So they're medical grade.
Is there a difference between the medical grade and the cosmetic? So we're talking in a pharmacy, it's by default medical, and in other like department stores, that's the cosmetic stuff, right?
Yeah, I mean, if you want to differentiate between them, normally things in pharmacies are medical grade. They might not have the exact ingredient or the concentration that your skin needs. And that is why, dermatologists would say, no, go for 20%, 30%, 15%, take this prescription retinol. But creams that are medical grade, yes, you don't find them in department stores. If you go to department stores, you might find a cream, let's say, that costs, I don't know, a few hundred pounds, that says lift and anti-wrinkle. But in general, it cannot have the enough active ingredients in it to really make that difference.
Yeah, it just looks amazing and smells lovely.
Yes,
Yeah.
and it's a very expensive moisturizer.
Yeah, I get that.
Most of the time.
Yeah. Here's a silly question. I'm slightly embarrassed to ask. What do you think of homemade remedies like coconut oil and castor oil for clear skin and these things?
Well, if you have acne-prone skin, it's going to make your acne much worse. Other than that, if you don't have acne or you don't have acne-prone skin, the only thing they would do is hydrate your skin or make it look shiny temporarily. But they do nothing with regards to exfoliation, collagen boosting, anti-wrinkle, scar treatment. They have zero effect. But the fact that they're oils, they hydrate the skin. So it's just more hydrated. They're like moisturizers, but that's it. But if you have acne and if you have acne-prone skin, you're going to get side effects.
Okay. How about those people like me who have extremely oily tea? It's a no-no to put extra oil on top of that, right?
Yeah, no, you would go, if you're looking for a sunscreen or a moisturizer, of course, go to a pharmacy to start with, look for a good brand, and then look for something that says for mixed skin or combination skin or oily skin.
Is there something bad in terms of daily practices or routines that we all do and we shouldn't?
And as far as skincare, you mean?
Yes.
Yes. Never ever sleep with your makeup on. That is something some people do and they don't realize its impact on their skin. And never squeeze your spot when you get it. Many people are tempted to just squeeze that spot because you take out the pus and then, it's gone, because it doesn't go and you just flare it up and it might scar.
What about the junk food of skincare? Something that I should really, really never buy. I'm thinking in my head that I use a tanning. I mean, I'm tanned enough. I don't even. I put on my legs tanning cream. Obviously, it's not good, right?
Not at all. It's very bad. Tanning oils, they're very bad. But I still get teenagers who say, "Oh, but I'm going to the beach. Can I use my tanning oil?" And it's very hard for me to sometimes, most of the time they listen to me. I mean, I can relate to them, but if it's very hard for me to convince them, I would say put your sunscreen on all over your legs, SPF 50, and then if you want, put your oil on top of it, if I can't convince them. But that, yes, absolutely, that is something really bad. I think also these ready-made face masks, you buy them, you put them on your skin, and they're supposed to do things. They're like these cheap masks, and sometimes you don't know what's in them.
Ready-made. What's ready-made in them? They're
so many different things. Yeah, so many different things. Teenagers love them. They just buy them, and sometimes they're shaped like a strawberry, or they smell like a strawberry, or
that's enticing.
Yeah.
So, do you recommend masks or no masks at all?
I wouldn't. If these. They're like we're talking about junk food masks. No, I would not.
Okay. Skincare is full of misconceptions. What are the biggest ones?
That skincare can, be magical. It can lift the skin. It can prevent sagging, and no matter how good and how medical grade and prescription skincare is, there are some forms of aging it cannot treat or prevent, like the expression lines we talked about, the volume loss, the sagging, the gravity, cannot do it. So even if a cream says lift and tighten,
surely
no matter how good it is.
It
can improve your collagen and tighten in a way, improve fine lines, pigmentation, fine wrinkles, but that's where it stops.
Okay. Now, we can't have an accomplished dermatologist like yourself without talking about brands. We're not sponsored by anyone, and there is no financial transactions between the podcast and the guests. But again, we want a shortcut for our viewers. If you could please advise on one or two brands for their purity, efficiency that you personally recommend, that would be amazing.
Yes, absolutely. So there are a few brands which people can go and buy in the pharmacy without needing my help. I like there's a brand called Aven. It's
Even.
Avene.
Okay,
It's
we'll add the links in the description.
It's a French brand. I stock it in the clinic, and I recommend its products to my patients. And it has ranges for rosacea prone skin, acne prone skin, dry skin, eczema prone skin. So then you can choose your moisturizer, your sunscreen, your face wash based on your skin condition or skin type. There are others that are good, like La Roche-Posay or SkinCeuticals. SkinCeuticals has things like vitamin C and AHAs, which you can choose from. And then there are others that are more prescription. Bioderma is a good brand as well. Bioderma is a good skincare range. Again, you can choose sensitive skin, red skin, acne skin, oily skin, eczema. Then you get all your things. And there are the others that are more medical grade. These are medical grade, but I mean there are things that are prescription. For instance, I prescribe Obagi creams, and these are some of them are prescription. They're very good creams, but there's a range that can be bought also without a prescription by pharmacist recommendations, which are called ZO.
Okay. Let's move to treatments at your clinic. I went through your website and I was totally overwhelmed by how many procedures and treatments that you offer. I wasn't even looking for a treatment. I was just trying to educate myself a little bit. How do you decide which treatment goes for which condition or skin issue?
So whether we're talking medical treatment or aesthetic treatment.
Of course, there's a difference. Now, you do cosmetic and you do medical procedures, right?
Yes.
You also do surgical and non-surgical?
Yes.
Okay. And you mentioned something about, you have an examination, you look at someone's face, but how would you decide? Let's start with cosmetic.
Okay.
How would you decide if I have, let's say, wrinkles or pigmentation? How do you decide which treatment is best for which skin?
Yeah. So if we're talking about cosmetic aesthetic treatments, we're talking about beautification now. So this has to come first and foremost from the person himself. We call them patients. They're not patients. They're not sick, but we call everyone patients. We don't call them clients. So I give them a mirror and I start off by saying, what do you want me to address? When you look in the mirror, before I tell you what I would do for your skin, because like you said, I have so many things I can do. You tell me, when you look in the mirror, what is it that is bothering you? Mm-hmm. So they might start by saying, I mostly hate this sagging. I don't like the hollow dark circles under my eyes. I hate this frown. It makes me look angry. I hate my spots. I don't like my neck. I hate my hands. They make me look aged. So that's where we start off from. Many times they know exactly what's bothering them, and many times they also know what they want to do. But if not, I would start first by addressing what bothers them. So if it's expression lines, I would say, of course, I need to do Botox for you. If you're bothered by your dark circles, this is what I need to do. Yeah, you need to do these creams. I might need to do fillers. Or maybe, this is a surgical case. I need to refer you to the surgeon. If it's the skin and the pigmentation, I would look at the pigmentation. Is it sun damage only, and can I solve it with some lasers and peels? Is it sunspots, or is it melasma? And then I have to prescribe some creams or do a peel in the clinic, or tablets even. What is it about the jowling? Can I solve it with my lasers and my high-intensity focused ultrasound, HIFU treatments with my injectables? Or is it too advanced that, you probably need surgery? Is it your broken lines and facial veins? Then this is the laser. So I have multiple lasers at my practice, multiple different machines that I use, and multiple different injections and procedures that I do.
You just talked about fillers. I've never done anything to my face, but one of my friends did dermal fillers. What are they and how could they help?
Fillers are what their name describes. They fill the gap. So they repair volume loss, or they restore the volume, and they're not supposed to overfill. So when you use fillers and you keep injecting, this is when you get the fake look, the big duck lips, the two huge cheeks. This is overdone. But fillers are supposed to restore your younger look. When we had, the young face has an inverted V look. So it's an inverted V. And as we age,
okay.
so it's this way.
Okay.
This way. And
okay,
as we
I get
age, things start sagging and we lose, this fat starts migrating downwards. So things start migrating downwards. So, sorry, not inverted V, inverted triangle. So the triangle is inverted as we are young, and then we start losing that.
Yeah,
so
that's why we.
Yes.
Okay. Ideally, that would be my younger self.
Yes.
But now, I think it was a year ago when, honestly, I think it was all of a sudden overnight. I looked at the mirror and I thought, this has dropped a little bit down. This is not how I looked yesterday. That's exactly how it happens. But luckily, there are faces that are structured like that to begin with a lower bone. So I didn't really bother with it. But my younger self was like that.
Yeah, so dermal fillers are composed, mostly the most common ones are hyaluronic acid, which we inject to restore volume and repair volume loss. There are other dermal fillers that are made of different ingredients, the calcium ingredients and other things. But the safest and the ones that are fully absorbable are hyaluronic acid fillers. There are some injectables that don't necessarily just fill the gap, but they push your skin to repair itself and to fill up things like polylactic acid, also known as Sculptra. And then the newer ones would be the polynucleotides, which are injectables, but they're not fillers. They just go and they push your DNA to work better. They push your fibroblasts to smoothen out the skin. So multiple different injections. There are hyaluronic acid injections, and there are others, like for instance, platelet-rich plasma or PRP. People know about this. It's special tubes whereby we extract blood, your own blood, spin it in special machines called centrifuges.
Okay, I want to wrap my head around this.
Yes.
Say that again, please.
So it's called PRP or platelet-rich plasma.
Okay.
This is a treatment that has been used for many, many decades in areas other than aesthetics, like, for instance, in surgery, in bone surgery, orthopedics, sports injuries. Our blood naturally has substances called growth factors. It's present in our serum, in our blood, all of us. Multiple growth factors, epidermal growth factor, vascular endothelial growth factors. These are things that are in our blood. And our blood's, one of the purposes of our blood, or its job, is to rush into any area in our body where there's an injury, to repair it, to repair the injury, to repair the trauma. So there are special tubes, like test tubes, like the ones they use when they extract your blood, but these are special, much more expensive tubes, and they have a gel in them. So we extract your own blood in it.
How much?
5 cc.
Okay.
Just 5 cc. Put it in a special machine called a centrifuge. I have it in my practice. Spins it at a very fast speed, and that separates the blood, which is the red blood cells, white blood cells, from the plasma. And that plasma has the concentrated growth factors. That plasma is then extracted, and so it's your own natural plasma. And it's injected normally, like, let's say, athletes, they have sports injury. They do the PRP and they inject the plasma in their muscles. So that speeds up their recovery so they can go back on the field. Then when they're doing bone surgery, they might inject plasma, PRP, in the area to boost it. Their own, the blood, the person's own. So in aesthetics, I use that in the clinic a lot. So you have the tubes, and I do that, and I extract the plasma, and I use it for two things: hair loss and skin. So when it's injected in areas where there's hair loss, of course, in combination with other treatments for that specific hair loss. But some types of hair loss, like for instance, you lose your hair because you've been on a very strict diet. That boosts the repair process, so your hair grows quicker. After a hair transplant, hair transplant surgeons would refer patients to me to give them PRP to boost that growth of that hair follicle that they implanted. And in cosmetics, we would do injury like microneedling. do a little injury in the skin and apply or put those growth factors, plasma, and that also stimulates the skin.
Yeah, I watched one of your videos. You're talking about microneedling and CO2. One of my friends, the same friend who did dermal fillers, she also did CO2 laser in this section of her face. It was last month and it was her birthday, so I wanted to give her a little thing. But she said to me, I'm hiding from everyone. So I dropped by and I saw her face. This area looked slightly burnt.
Yes.
But when I saw her later, 2 or 3 days later, she was perfectly fine. And there was a sense of clarity, tight clarity.
Yes.
I'm not sure how to describe it, but it's like a baby skin. And I look, ooh, wow, that's nice. Then I've seen one of the videos, you talked about microneedling, how you inject small needles into the skin. And I'm going to quote you on one of these things. Actually, this is related to the CO2 laser, creates micro wounds which can cause the skin to, and I quote you here, rush to heal itself. And by healing these micro wounds, I will create newer collagen and tighter skin. I found that image absolutely fascinating, and I was wowed by it. So by inflicting like calculated damage to the skin, it triggers its natural ability to fix itself, right?
Yes. Yes, this is the concept behind microneedling, chemical peels, fractional laser, CO2 laser, or the non-ablative fractional laser. So CO2 is an ablative laser. It actually uses light, which is the CO2. Like, lasers, we can do a podcast specifically about lasers. I can talk forever about lasers. But lasers, each laser has its own wavelength, specific wavelength, and each laser is absorbed by a certain ingredient or substance in the skin. CO2 laser is absorbed by water in our skin, and it has a very specific wavelength. And when the CO2 is absorbed, when we hit, of course, it's very calculated. So I would specify the shape, the density, which means the number of dots per pulse, the energy, the power, how deep I want to go. So it's very precise and very calculated. And it's actually I love doing CO2 lasers. It's my one of the most common procedures I do, mostly in the winter time. It does create micro injuries in the skin, very calculated, and with even a certain shape. So if you look at one of the videos, when it goes close up, you can even see the pattern. So I can choose a square, a rectangle, a hexagon, and that's how they hit the skin. So it creates those injuries, and it also, that heat that builds up, shrinks the skin a little bit, or that heat coagulates the skin. We call it coagulation, thermal coagulation. And I use CO2 to treat wrinkles and scars mostly. It does have a downtime more than 2 or 3 days. It's 7 days. You need about 7 days for the scabs to completely fall off and your skin to heal. I prep them before, and I give them very strict post-care instructions. And yes, they need to hide from the sun during that period. Otherwise, they get pigmentation. So they need to be indoors for the CO2 laser. And it, does wonders on wrinkles, clarity, pigmentation, and scars as well.
How does these treatments feel, like microneedling or the laser? Is it painful?
So I hate inflicting pain, and everyone says you have a very gentle hand, even when I'm doing injectables, because I don't like patients to feel pain. So I do numbing creams for almost everything. So with a numbing cream, let's say we're talking about the CO2, I get a strong, really strong, we prepare it in the laboratory, numbing creams. Once it's applied on the skin and left for enough period, your skin is numb. So you do feel a bit of a sting, but it's bearable.
Yeah, that's good. Also, in one of your videos, I've heard you talking about liquid facelift. Until now, I'm resisting the temptation of asking ChatGPT, what's so liquid about it, and is it different than like surgical facelifts?
Yeah, liquid facelift refers to injectables. So you're injecting liquids to tighten and lift and give that face the inverted triangle look again. So liquid facelift refers to a combination of botulinum toxin and dermal fillers injected in a way to restore that balance, like we said, lift and fill. And in contrast to a surgical facelift, the surgeon would cut the sagging skin, remove the excess skin, and stitch it back up in very simple terms. Whereas a liquid facelift, we're injecting liquid, which is Botox and fillers.
Let's say I'm a middle-aged woman, and I don't have any medical conditions, but I just want a boost to make me look fresher. Nothing too invasive or dramatic. What would you advise for me to glow as long as I can?
So if I'm looking at your skin, and if we're talking about you specifically, if you don't have...
not necessarily me, to be
just
honest.
in general.
Yes, in general, because this is what most women look for, just a fresher look.
So a very mild chemical peel might give a little bit of freshness. Microneedling is not that invasive. You just get redness for a day or two. Microneedling in combination with platelet-rich plasma, PRP, can give a fresh, nice glow. Lasers that are not invasive, so not the CO2 laser, because that's, you need a week off. But things like the non-ablative fractional lasers, like the Nd:YAG laser. I have a laser at my clinic called the Clarity laser, which, it's not painful, doesn't need downtime. You can do it in your lunch hour, go back to work, wear makeup after it, just gives a nice glow.
So it's a half a day downtime kind of thing?
Not even less, even nothing. And things like skin boosters, like there are some skin boosters that can be injected, no downtime. It's just a little prick. Sometimes you might have a little spot where the needle enters, things like Profilo or skin boosters. So these are gentle, easy things, no downtime, and they give a glow.
Here's another funny question, and I'm not sure I'm being scientific here. Can I do mix and match with these treatments? Like, can I have a laser treatment and a microneedling procedure, for example, on the same week? Are there any downsides to this approach?
Yes, it depends on which treatments I am recommending to my patients and what treatments they are doing. Some treatments can be done on the same day. Others cannot be done within a week, so it all depends. So your question was, can I do microneedling and laser,
for example,
in the same day? Normally not, if we're doing them on the same area. So if we're doing procedures on the same area and they both like abrasive procedures or lasers and peel and lasers and microneedling, I wouldn't do them on the same day. But for example, you come to me and you say, or I tell you, you would need, let's say, botulinum toxin here, fillers here, lasers here. Yes, I would do them on the same day.
I have a question about skin tones. Thankfully, we're a very multiracial country here in the UK. Does my skin tone, whether it's dark or fair, affect which treatment I might have?
Yes, that mostly relates to lasers, because lasers are light, and some lasers are absorbed by melanin in our skin that gives it its color. So some lasers are not safe to be done on dark skin tones or tanned skin, because then you would have some side effects. But apart from that, apart from lasers or maybe some chemical peels, your skin tone will not necessarily prevent you from doing other procedures, like injectables, microneedling, skin boosters, some types of lasers. So, and also with the right preparation and the right post treatment and following my guidelines specifically, I have a good experience even in treating darker skin tones with lasers, especially because also before I practiced in the Middle East, and here I do get people from all skin tones, ethnicities. So I have a very good experience in treating dark skin tones.
I have one of those IPL hair removal devices at home. I got it from one of the pharmacies on the high street. They are very, very efficient. But I've never questioned whether they are safe or not. Are they?
They are less powerful, much less powerful than the machines, even the IPL that we have in the clinic, that's doctor-led, or, these big machines. So these, the ones we have in our practices and we use, are much more powerful than the home health devices. In that sense, they are safer. They are safe, quote unquote. But of course, you need to follow manufacturers' instructions. If your skin is tan, don't do it, because you can still burn yourself. If you have a rash on your skin, if you have spots, don't go ahead and laser, because then if you have a skin infection. So you need to still follow the guidelines.
Away from these lovely feminine things, do you sometimes see men at your clinic looking to look nicer?
Yes, I do get men. I get more women, of course, but I do get men. The common things they would do would be Botox, because they don't like the frown, especially if they are like in an executive position, and they are in a position of authority. They have people working for them. They don't like to look angry all the time. They do things like under eye fillers or dark circle treatment, because it makes them look tired and they don't like that. They might do things for spots, for brown spots. They might not like moles that I would remove. So they do things, but of course, less than women.
Please share with us the one thing that I can do at home daily to support my skin health without the need for any procedures.
Use your sunscreen.
Use your sunscreen, yeah.
Every day.
I was born and grew in Egypt, and I spent a lifetime in Egypt under the frying sun for days and days, never used sunscreen. I guess that's bad now, but I've only started using sunscreen in the last 3 or 4 years because I never had that education. I never knew that it's super, super important until I heard a dermatologist in a really nice podcast saying, use your sunscreen. So that's when I started. Let's move to skin conditions, please. I think we all get some sort of spots or hyperpigmentation. Let's say pigmentation. I have a little bit of ones here, and I think nothing of them, from what I understand, they don't usually need any medical intervention. But what should I be looking out for in my skin that might indicate that there's something ominous happening here with these spots?
So there's a slogan, I think it comes from the American Academy of Dermatology, which I'm also a member of. It says, see a spot change, see a dermatologist. So basically, skin cancer comes in different forms and colors and shapes. But a skin cancer spot can be a red spot, can be a brown spot, a black spot, can be a mole that has changed and evolved and grew. It can be a brown or a mole that suddenly becomes irregular, has asymmetry, different colors. It's more like skin cancer or like ominous skin spots. Statistically speaking, are more common in elderly people, like middle age and older elderly people, and they're more common in people with fair skins, like skin type 1, 2, 3. So basically anything, a spot or a rough spot that won't go away, you apply moisturizer or a cortisone cream and it's still there, starts growing, go see a dermatologist or go to your GP, and then if he or she suspects, they will refer you.
Okay, so if it changes color, if it changes size, if it changes texture, I'll speak to someone.
Yeah. Okay. If you're not sure what it is it something hard or a lump that is growing? Basically, if you're not sure, ask a doctor.
You did mention loads and loads of factors and variables that we mortals wouldn't be able to decipher them. I find skin conditions very, very mysterious things. I once had something, I actually practiced pronouncing them, but if you could please help me. This.
Rosacea?
Rosacea.
Yeah.
I had that once. I think I was 24. It started with a patch in my back, and all of a sudden...
rosacea, sorry, not rosacea. This is different.
Oh, God.
Pityriasis rosea. Yes.
Rosea. Okay,
Yeah.
but there is a name before that. It started as a patch in my back, and it spread like a horror movie all over my back. Was the most I don't know, horrific rash. And I've seen my dermatologist. He passed away back in Egypt now, but he said to me, "Don't worry about it. It's going to go away. It will That's exactly what happened. It was like a slap on the face.
Yes.
Thankfully, it wasn't painful, but it looked like I couldn't have imagined that this will disappear in 3 weeks. And it did.
It does.
Amazing. And I was told it's a once in a life condition. Once you get immunity, and it goes away. Another thing I have is a birthmark. My cousin has exact the same. He's a male. Has exact the same birthmark in the back, on the same spot, the same shape, same size. Should we worry about birthmarks?
It depends what birthmarks they are. So we're talking about brown birthmarks, not red birthmarks. Red birthmarks, everyone knows they are not cancerous, like vascular birthmarks. Brown birthmarks can be completely benign and never change into skin cancer. For example, things like cafe au lait macules, which are brownish stains, and they are birthmarks. They can be on the face, on the body, and these never change into skin cancer. Nowadays, we use an instrument called a dermatoscope, as dermatologists, which wasn't there when I studied dermatology and started practicing, but for the last, let's say, 15 years, it's become something of a tool that we need to use. So it's like a skin microscope where we would look and it would magnify the cells and the structures in the skin, and it's science by itself. So there are some features that tell us and give us an indication on whether the birthmark or the mole or the brown spot is cancerous or not. But of course, you can't use it. Some GPs have learned how to use it, in a basic sense. But for you, for instance, you have a birthmark, a mole, a congenital mole on your back. Familiarize yourself with how it looks. And then maybe once in a while, every 6 months, something like that, take another picture or look in the mirror. If you see it changing, the rule, the old rule is called the ABCDE rule. So A stands for asymmetry. The mole starts becoming asymmetrical. B stands for border, so an irregular border. So before it was like a really sharp border.
As a like a grape kind of thing.
Even if it's shaped like a grape, if it hasn't changed, you shouldn't be worried. But if it starts changing in as symmetry, border, color, it was tan, and then you see specks of black in it or specks of white. Diameter, D stands for diameter. It was 6 millimeters and now it's 7, 8, or E, evolving. That's what I talked about. Then of course have it checked.
I'm not thinking of stress. Let's say chronic stress, because nobody has zero stress in their lives. How can stress affect my skin negatively?
So certain diseases are flare up and are triggered by stress. Psoriasis is one, acne is one, rosacea is one, hair loss is another one. So in an indirect way, stress reduces our immunity and causes probably more inflammation, and that is how some eczema, even when kids or students pass through exam period, their eczema flares up and becomes worse. So this is, it can, yes, definitely stress can worsen some conditions.
Let's talk a little bit about hormones, our lovely female hormones. In teenage years, we get a huge surge of hormones followed by a kind of plateau till we get pregnant and have another surge of hormones, then another plateau, another pregnancy, till we reach perimenopause and menopause years. I want to know from you, how does my skin react to all these fluctuations of hormones?
So in the teenage years, as we talked, your acne surges and flares up. In pregnancy, you can get things like melasma or cloasma, or the mask of pregnancy, which is the pigmentation on the face that can happen in some pregnant women. Perimenopause, menopause, you can get a few spots as well. You get dry skin, you get vaginal dryness, you get some hair loss because of the hormonal fluctuations in perimenopause and menopause, and hormone replacement in that period HRT in women who can take it or who get prescribed it can negate these side effects.
We're having such a beautiful early spring here in the UK. Today is Good Friday, and soon enough it will be summer and we will go on holidays, fry under the sun. You already told me that it is not good for me and I do need to use sunscreen. I want to drill down on this a little bit. Why is sunburn bad for my skin, other than the obvious factor that it's painful?
Sunburn and unprotected sun exposure causes DNA damage, and DNA damage can predispose you to skin cancer later in life, and skin cancer can be deadly. Melanoma is deadly. And if we're not talking about aging, like the sunspots, the wrinkles, the laxity, this is all sun-induced. If you don't want to mention those, if you do not protect yourself and you get sunburns, you sharply increase your risk of skin cancer. And sun is the main cause of skin cancer. Of course, you can get melanoma in sun-protected areas, but it's mostly, and melanoma can be hereditary, you can have genes for melanoma or basal cell carcinoma, but sun is the major factor. So by exposing yourself to unprotected sun exposure, and the fairer your skin is, the lighter your skin is, and the more burns you get, the more DNA damage, and the higher the rate of getting skin cancer when you are more mature.
Oh, so when you say more mature and when you say later in life, does this mean that in my 20s, if I fry myself, bake myself under the sun and get the sunburn, then I damage my DNA? Does this increase the risk of skin cancer 20 or 30 years later?
Yes, 100%. Yes.
Wow, okay.
It increases your risk. It predisposes you to skin cancer. The more sunburns you do, the higher exponentially the risk of skin cancer that can happen. So I still get really anxious when I sometimes go to beachy areas and I see people up until now, 2025, sitting in the sun, burning, and it scares me when I see a sunburn. I almost feel like rushing to them, and of course that's not polite. I would never do it, but I almost feel like saying, please put on a t-shirt, please move away, please wear your sunscreen, because you are increasing your risk of skin cancer.
Okay. Now I'm wondering, why does skin cancer take such a long time to manifest itself? I'm just thinking how scientists could make that connection, the causation between the DNA damage in my 20s and skin cancer 20 or 30 years later.
It's a lot of scientific studies, causality, evidence-based medicine. Mutations happen, but then it takes years for that mutation to progress into skin cancer. It takes years, can take decades. So it's a lot of research, lots and lots and years and decades of research and centuries of research that have gone into proving that causality between sun exposure, DNA damage, and skin cancer. It's the same way that applies to smoking and lung cancer. So if you smoke 1 pack a day for a year, you're not going to get the lung cancer immediately. It's over time, this smoking which leads to lung cancer and heart disease. So it does take time.
Now, how do I choose the perfect sunscreen for myself? What should I look for on the package? Give us a complete guideline.
So SPF is the main thing. It's called sun protection factor. It's the number that you see on the package of the sunscreen. And it refers to the amount of time you can sit in the sun with your sunscreen before getting burned. So which means that sunscreens are not 100% protective. So let's say an SPF of 50 means that compared to sitting in the sun without any sunscreen, if you apply this sunscreen, you can stay for about 50 minutes before getting burned, but you will still get burned eventually. So the number you should be looking for is at least 30. Don't go for anything below 30. the standard, there are nowadays in most sunscreens, good medical grade sunscreens, is 50. But I would say at least 30. Anything less than 30 is not really protective enough, especially if you're going on holiday, beach, snow, and there's a lot of sun exposure. And then you should look at what does it protect from. So SPF refers to UVB, ultraviolet B, which causes most damage, DNA damage and skin cancer. But there's also ultraviolet A, UVA, and more recently, research has found that also visible light, blue light, infrared light can damage the skin. So ideally, look for something called broad spectrum sunscreen, which means it protects against UVA, UVB, and visible light. And the third thing is look at the texture of the sunscreen. If you have oily skin, go for a sunscreen that says for oily skin, does not clog pores. You can get a spray sunscreen. I like it a lot for children because then you can spray it on even when they're wiggly and jumping around. Lotions compared to creams. Tinted. The last thing would be if you have pigmentation and melasma, go for a mineral compared to a chemical sunscreen. So mineral sunscreens or physical sunscreens, and especially tinted ones that have a bit of makeup in them.
How
like
would
a
I know
little
the
color.
difference between the mineral sunscreens?
It says on it.
It would say.
It would say physical or mineral sunscreen. So they're more protective. So people with sun allergies, sun sensitivity, photosensitivity rashes, or pigmentation, melasma, I would recommend mineral or physical sunscreens for them, or tinted sunscreens. Some sunscreens have color in them, like a bit of makeup, like what I have now. So it just gives a little glow, a little color.
So let's say I spend the whole day on the beach. Should I top off on my sunscreen every few hours?
Yes, absolutely. So sunscreen, if you're on the beach, make sure first of all to apply it 20 minutes before you go out in the sun. And then if you go out and you're swimming, even with your sunscreen, we always recommend wear a wide brimmed hat, avoid the sun at its peak, that's between 11 and 3, and reapply your sunscreen every 2 or 3 hours. Yes.
Okay. Should I cover my ears? I've always wondered about that. So all exposed areas.
Skin cancer can happen on the ears. It can be aggressive on the ears. Yes, ears. If men are bald or they have balding hair on the scalp as well, because they can get skin cancer on the scalp. Don't forget your hands, your chest, everywhere. Yes, your ears, your lips.
Lips.
Yes, your eyelids.
Yeah. Now I remember my nan, may she rest in peace. It was years and years ago, maybe 14 years ago, was just a child when she refused to go to the beach with us because she was concerned about the sun. And that was at a time when we didn't even have sunscreens on the market. And my mom told her, you're going to be under the umbrella, you're going to be just fine. And she said no, because the rays bounce off the sand and hits her face. Was she right?
Absolutely. So you do get ultraviolet in the shade. You get it in cloudy, rainy days. Of course, you get more when you're in direct sun on the equator. Noon time, of course, that's its peak. But you can get burned. Your nan is right, you can get burned if you're sitting under the umbrella. If you don't have sunscreen, the light gets reflected and it travels in to the shade and it can burn you. That's why people who ski get sunburned on their faces badly if they don't wear sunscreen, because the sun rays get reflected from the white snow. They hit them on the face and they can get badly burned. I had a friend once who told me her son got his eyes burned, his cornea was burned while skiing, actually because he wasn't wearing goggles. The intensity of the sun up in the mountains with the white snow burned his eyes. His cornea got damaged.
Wow. What about these UV protective swimwear or beachwear that supposedly shields the entire body from the sun? Are they effective?
Yes, they are very effective. They are very common in areas like Australia, where the rate of skin cancer is extremely high because they have like a deficiency in their ozone layer. So it's very common for people there to wear fully protective UV reflective swimwear, long sleeves, long pants, and they to protect you from the sun. They are good to be, it's good for us to have our children, our babies wear them.
Hearing you talking about children, I grew up in Egypt, and sunscreen wasn't a thing at that time. As I mentioned, nobody I knew used it. So I think I carried that negative legacy when I moved to the UK. I now have a 9-year-old child, and sometimes I remember, but I just ignore applying sunscreen on her. We're rushing hours. I think, oh, she's half Egyptian. She never burns. She's going to be fine. Am I doing her a disservice?
So the lighter the skin type, so Fitzpatrick skin types go from 1 to 6. 1 being the very fair-skinned, blue eyes, blonde hair, and those are the people, skin type 1, who always burn but they never tan. And those have the highest risk of being burned and getting sun damage and skin cancer, all the way to skin type 6, which is black skin. And those are the people who never burn. So the lower the Fitzpatrick skin type, the higher the risk. And the higher is the lower the risk of skin cancer. So it's a spectrum, but everyone needs to wear sunscreen. Of course, black people, black skin, risk is very low. They have a lot of melanin naturally that protects them. So no, they don't really need to wear sunscreen. But the lower you go on the spectrum, yes, you do need to wear sunscreen all the time.
I should behave,
yes.
really, and do my job as a mom. What about tan beds? They are super popular in cold countries like here in the UK. Are they a no-no or in moderation?
They are a no-no. They have been in multiple studies linked to skin cancer and skin aging. And for us, we say no, no, no. In some countries, they're even banned. Hopefully here in the UK there will be some kind of law that will ban them because they're intense UV exposure multiple times. They do have a risk of skin cancer. Of course, when I tell people like to tan, they like that glow, they think it's healthy. For us as dermatologists, we try to convince them that no tan is healthy. The fact that you've tanned means that you've had some kind of DNA damage. You have damaged your skin. But at least do it gradually. Do not burn. So at least, if you do want to tan, do it very gradually. Use your sunscreen. Get that tan very slowly. Don't just burn yourself and get blisters and peel. And that can happen with sunbeds as well.
So we eventually come back from holidays with a very ominous tan. What should I apply on my face to reduce the sun damage?
The only, the mostly evidence-based thing that you can apply would be prescription tretinoin or retinol, which are vitamin A derivatives. Those creams can reverse to a certain degree the damage, but not fully. Like when you have a mutation, it has happened. But vitamin A derivatives applied on the skin can, sometimes we use them to treat some kinds of precancerous lesions, or they can reverse to a certain degree sun damage.
Okay. And you mentioned that these will need a prescription, right?
To higher percent, yes, you need a prescription.
Yeah. So you're telling us with very strong terms to avoid the sun and wear sunscreen, even in winter, even in the shade. I've read somewhere that sunscreens prevent my body from absorbing vitamin D. Is this correct?
So to get enough vitamin D, 10 to 15 minutes, maybe 20 minutes of direct sun exposure are enough per day. So you don't need to be sitting for hours and hours and burning and tanning in the sun to get vitamin D. And because here in the UK, we don't see the sun for several months, it's good to get a supplement, like take supplements, 1,000 units a day or 10,000 units a week of vitamin D during the winter periods. Sunscreen, if you apply sunscreen, doesn't prevent it 100% from vitamin D is made in your skin from sun exposure. So it does not prevent it completely. But of course it blunts it. So, but if you do want enough vitamin C, let's say you expose your legs to direct sun for 10 minutes a day, 15 minutes a day, that's it, you have your enough vitamin D. And of course you can always get the supplements, and it's recommended. There are some diseases which benefit from the sun. So sometimes we do tell patients with psoriasis, go in the sun, sit in the sun. Of course, don't burn yourself, because ultraviolet and specifically UVB, UVA, PUVA is a treatment for psoriasis. That's called phototherapy. So sun can be beneficial for some skin diseases, and it can be harmful for a lot of other skin diseases. So if you have rosacea, you have lupus, you have to stay out of the sun.
Now, if I want to damage my skin, increase pigmentation, have the sagging and the dullness and all the rest of that, what would I do?
Smoke and sit in the sun.
Smoke. Yeah.
And sit in the sun, unprotected. A lot of high intake of alcohol also can have some deleterious effects on the skin. So high alcohol consumption, the same way it affects other organs like the heart and the brain, it can also impact.
Am I correct in assuming that the sun is the main cause of skin cancer?
Yes, in all of them.
What about genetic factors?
Yes, they do play a role. Definitely, there are some genes that predispose you for melanoma and genetic variabilities, but a lot of the times they are also compounded with sun exposure. So if you're exposed to the sun unprotected and you do have that gene, your risk is higher. You do get melanoma in sun-protected areas as well. I'm not saying it does not happen, but it's more common in sun-exposed areas.
Yeah, talking about the areas that do not see the sun. If I have like a mole or skin irregularity, should my GP or dermatologist check my entire body?
If it's a melanoma, yes, any skin cancer. If we diagnose skin cancer, we do check the entire body, of course. And if you've been diagnosed with melanoma and your melanoma has been removed and so far has not spread, so based on the depth of the melanoma that is excised and removed, we have an algorithm to decide, and of course there are oncologists that get involved and surgeons.
I have some statistics here for you, please, though I'm sure you have more accurate ones. Skin cancer cases in the UK have been rising, with melanoma cases projected to reach around 20,800 in 2024. We're now in 2025, marking nearly a 30% increase over the past decade. Approximately 17,000 of these cases are considered preventable. I'm assuming preventable because we expose ourselves to the sun. Is this correct?
Yes.
Okay. Projections indicate that non-melanoma skin cancer rates may rise to reach 310 cases per 100,000 people annually. Why do you think we're seeing this rise in cases?
More people are getting exposed to the sun, and they're still unaware, but the mortality is dropping even though the cases are rising because of early detection, because of awareness, because the earlier the melanoma is removed, the smaller it is when it's caught, the higher the chances of cure or remission from that melanoma. GPs have a high rate of awareness about what is suspicious, what is not. And there's something called the 2-week wait in the NHS. So if a GP sees a spot and suspects a cancer, specifically a melanoma or a squamous cell carcinoma, which are aggressive, he can or she can put the patient on a 2-week wait scheme. That means compared to a year wait for things like psoriasis, the patient gets seen by a dermatologist within 2 weeks.
That's brilliant.
And then if a dermatologist in the hospital sees the lesion and confirms that it could be melanoma or squamous cell carcinoma, of course they cannot prove until they remove it. Then again, within 2 weeks, that lesion is removed.
On the mention of the NHS a few minutes ago, and the NHS is one of my favorite subjects. Dr. Injibar, you worked in the NHS as a locum consultant dermatologist from 2018 to 2022. How was that experience for you?
I loved working in the NHS. I really enjoyed it. It has its drawbacks, as in mostly there's not enough time given per patient because there's such a huge backlog, and I get given 10 minutes to see a patient. Many times this is not enough. So that was frustrating. But I think the NHS is an amazing system, and it's an amazing healthcare system. And although people complain a lot about it, and although, of course, there are improvements that can be done, but I did enjoy working at the NHS and being a locum dermatologist.
Yeah, I totally agree with you about the NHS. It's an amazing service. And I think I mentioned that zillions of times now on this podcast, that I have a list of diseases and conditions, and they are all under proper management. There is a hiccup here or there, but I wouldn't really worry about that. But it's an organization totally worth saving and maintaining 100%. For the rest of us. Dr. Injibar, we usually end our episodes with big question, big picture kind of questions, like visionary, moral, ethical, and I have lots and lots of them for you. Okay. Are there any new technologies in medical dermatology, not cosmetic, in medical dermatology that excite you, or you think they're going to be the future?
There are a lot, but if I want to mention one of them, me being a laser specialist and a laser surgeon, I always get excited about lasers. And there's a new, relatively new kind of technology in lasers, the 1726 nanometer laser, which treats acne without the need for medications and drugs and tablets.
So it does not. Thing?
Relatively new. Yeah, it does not treat, it's not the scarring, like I do lasers to treat acne scars. That's different. These we have had for quite a long time now. But it's a new wavelength to treat active acne. So treating acne with lasers compared to tablets. So for those who cannot take tablets or medications, or it's something new, and it will improve, and it will progress, and eventually we'll have a better technology than the one that exists now, which is faster, more efficient. But that's something that's medical, blending medical and aesthetics.
Yeah. I read on your website that your approach emphasizes embracing the healing process. Could you please elaborate on this philosophy?
Yes. When patients or people finally come to me or reach my practice, they need results. They need to see results. They sometimes have been to other clinics and been treated by maybe beauty therapists, or done lasers, or mild peels, which have barely touched the surface. Yes, you don't get downtime, but then you don't see dramatic results. I still do procedures that don't have downtime. Of course, I still do that, and I approach each patient differently, and I ask about their lifestyle, their work. But if they can embrace downtime, I like to do procedures that really work. For example, and also depends on the condition. They have melasma, pigmentation, sun damage. I like to do like deep peels, aggressive peels, or CO2 laser, which give the wow effect later. I hold their hand throughout the procedure, but then they see the results. For example, they have things we call xanthelasmas under the eyes, which are yellowish, lumpy things that are cholesterol deposits. Yes, I can erase them with lasers over and over and over, but I can excise it and cut it out and put stitches, and that's one-time thing. They might have a bruise or a blue eye for a week or a few days, but then that's it. It's done.
Yeah. So I hope I get this right. So I've been writing notes. So you're telling me that the current treatments favor short-term solutions, minimal downtime, and maybe regular treatments. But you do things in general the other way around, like long-term solutions, more downtime, and maybe fewer treatment sessions.
Yes.
Is that correct?
Yes.
Okay, so yeah. Also, part of your ethos, you talk about achieving subtle yet noticeable improvements. But what if you see a patient who wants dramatic transformation to the point of maybe being unrecognizable? How would you deal with that?
That this mostly relates to injectables and dermal fillers that might make them look different and unrecognizable, overfilled. Those I try to discourage as much as possible. And because my approach is subtle and maintains the natural look and implements and augments some features that might be natural in your case, but you don't like. For instance, very thin lips. You're born with very thin lips. You don't like them. They don't match your face. Of course, I can fill them to make them more voluminous and give you a nice pout, but I wouldn't overdo it. Of course, if you have flat cheeks, I would fill them, but I wouldn't overdo it to the point that you look fake or artificial. So I try to discourage my patients from overdoing this, not to look fake.
It must be a fine balance because I'm wondering about the psychology of dermatologists. You guys must have like an urge to fix, repair, and perfect, these kind of things. So it must be a fine balance between having perfection and a natural look.
Absolutely, it's a fine balance, and we have to always remember as doctors that we swore an oath, which is the Hippocratic Oath, and I have it hung in my treatment room, and that is do no harm. And when you are even practicing aesthetics and cosmetics, it's still a medicine. It's an art and a medicine. And if you are doing aesthetic procedures, having in mind any like financial gain or following whims of the patients, then you're not really practicing good medicine, and you swore an oath to do proper medicine. So this all falls into this. And if some patients have a hidden agenda or a psychological problem that they're trying to fix by changing the shape of their noses or their eyes or their lips or their face. And we are trained as doctors to detect this and to not treat in this case, of
What
course.
would you tell them?
It's very delicate. It's a very delicate thing to do. Sometimes you might not succeed. Sometimes you might succeed in convincing them to talk to their GP, to refer them to a talking therapist. In my case, I would maybe do a little something that is not overboard, to give them a little satisfaction, but at the same time addressing their other issues. And sometimes just by talking to them, let them ventilate, talk about their problems, give them a mirror and try to convince them that, we don't need to do this. This looks fine.
Yeah. Dr. Injibar, you studied dermatology at the American University of Beirut, where everyone is so beautiful, incredibly beautiful. As they say, beauty is in the eye of the beholder. How do you see beauty? How would you define a flaw, for example?
I think everyone has a beauty naturally, but if you're someone who's bothered by the shape of your nose, the size of your lips, the way your face is sculpted, then I can help repair it and correct it. Beauty in general terms in aesthetics and cosmetic medicine is mostly defined as symmetry. So symmetry and having a third, and having symmetrical facial features is the general definition of beauty. That's why you see people like Angelina Jolie as being the standard of beauty, having a very symmetrical face and symmetrical features.
Yeah, I love beauty. I love looking at people's faces, and I love spotting beauty, even in people who are not conventionally beautiful. I always find something easy to look at. Do you also have this kind of syndrome? Do you catch yourself staring at people's faces?
Yes, of course, because that's how my eyes work and my brain works. But I find myself more focused on skin diseases, specifically acne. So when I see someone with acne and I see them hiding it behind layers of makeup, or I look at the skin and I see scars, that is what drives me. I feel like, I wish I can help that person. I wish I can tell him what to do and that they can seek help and improve it. Because I deal with correcting faces and flaws and skin at work all the time, I wouldn't necessarily focus on them a lot when I'm outside work. But yes, of course, I study faces and I study the skin. And in my mind, automatically, I make a treatment plan, even though we're just on the tube or, in the grocery store.
Yeah. I remember maybe 30 years ago when everyone who had I'm assuming now plastic surgery, looked like Cher, the American singer, if you know her, with popping cheeks. How do you avoid making multiple copies of the same chin, same cheek, same nose?
By embracing the individuality of the look, by restoring the way that face looked when it was younger, rather than changing it drastically to someone who is not them, by looking at what suits them. For example, someone with really thin lips and a really small face would look unnatural if the lips are plumped aggressively and to a big degree. But unfortunately, and specifically in where I come from, in Lebanon, everyone looks the same. So it has...
I found them really beautiful.
They are very beautiful.
Flawless.
Yes, but...
I was a peasant there.
Yes, but nowadays it's a lot of the same noses, the same cheeks, the same eyebrows, and the same lips, which I try to avoid in my practice.
How about taking ethnic uniqueness? I think you actually touched on that. I come from the Middle East / North Africa because I was born in Egypt from Egyptian parents. Surely I have different facial features than a white British woman, different than an Asian woman from Hong Kong. So do you take into account that ethnic uniqueness?
Of course, that's what I mentioned before. I take into account the ethnic, I take into account their facial features when they were younger. So we're basically restoring and repairing rather than changing and over-correcting. And also, I'm not a plastic surgeon. So plastic surgeons are the ones that cut and shape noses and they lift faces, and they can do things like a lip flip and a lip lift. So when they're, or, breast augmentation and all of these things. And they can also fall into traps of making everyone look the same. So everyone has the same nose. So there also goes the importance of educating the patients that, this nose suits you. A smaller nose with your wide face and big cheekbones would look unnatural. So it's educating the patients and making sure you maintain their ethnicity and their features. For instance, Asian people, if they completely do a full blepharoplasty and remove their hooded lids completely, they will look strange. That's not their ethnicity. So yes, of course, you have to maintain.
I feel that beauty treatments or skin treatments are a blend of medicine and art. How much of it that you do in your clinic is something that you studied in medical school, and how much of it is due to or down to your artistic sensibility?
There's a big part that is due to the artistic nature, and I view the face as my canvas or a sculpture that I'm doing, and there's no size that fits all. It's more like delicate, simple, not simple, maybe delicate, gentle things that are done. And when I'm treating the face, where I'm treating, when I'm doing lasers, doing injectables, doing fillers, I feel like an artist and I'm doing sculpture. And I keep going back and looking from different angles and telling the patient to turn and twist and look up and down. So a big part of it is art and artistry, and that is how you achieve natural looks. If it's just one size fits all, it's not a balloon that we're filling.
Yeah, I have seen before and after photos on your website, quite impressive. But how do you manage patient expectation if someone wants divine transformations? You're not a magician, are you?
No, I'm not a magician, but a lot of the things we do and I do are like magic.
Yes.
And realistic expectations are very important, especially when it comes to things like, can you erase my scars completely? Can you wipe them out? And can you make me look like Angelina Jolie? Or
I have that.
I have that, photo of an artist I found in a magazine. Of course, they're all airbrushed and photoshopped. Can you give me her lips? And you need to draw the line and sometimes say no, because this is not achievable. So it all boils down to patient selection, patient education, and knowing when to say no as much as you say yes.
I have to say that you have the smoothest, clearest
Thank you.
skin I've ever seen in my life. People talk about my glowing skin. I'm pale in comparison. It's like sitting in front of the sun.
Thank you.
It can
You
actually
have
be
glowing
distracting.
skin.
Oh, bless you. Thank you. But it can be a little bit distracting while I'm thinking of questions. Wow. Like, do you think this is due to the treatments that you had in the past?
Yes, absolutely. So anything I do for my patients, of course, I've started doing botulinum toxin when I was very young, and in my early 30s, mid 30s, I started doing dermal fillers. So they repair. I use all the active ingredients I told you about, and I tell my patients about. I've been wearing. I avoid the sun completely. I hate the sun. Cannot sit in the sun. So that has prevented me from getting wrinkles and laxity and sun damage in my 50s. And I do the procedures and lasers that I advise my patients to do.
Yeah. Dr. Injibar, where can we find you online, please?
So our website, the clinic is called Dermasurge, and our website is dermasurge.co.uk. All the numbers and all the information are on the website. We have Instagram, which is called Dermasurge London, and all the other channels that are available on the website.
Yeah, Dr. Injibar, I've always found dermatology a very challenging field. It's not straightforward by any stretch of the imagination. You break a leg, you fix a leg. You get a tumor, you extract the tumor. It's not as simple as that. But skin conditions are usually shrouded in mystery. When I was diagnosed with psoriasis, one of my professors said to me, in dermatology, you can walk into a maze for the rest of your life just trying to find the correct diagnosis. But you certainly know your way and you are at the top of your craft. To me, you strike an amazing balance between science and compassion.
Thank you.
And your warm character shows that perfectly well. The UK has won you. Okay. Thank you so much. Thank you so much for coming to
It's a pleasure talking to you. Thank you.